Yes, and this is the Palliative and End-of-Life Care Committee, and we are starting. So there should be audio playing now, and you should be hearing a voice. Okay, so here we are. Some people are having trouble getting in, and they're working with Courtney. We're having some difficulty with panelists, but I think it's going to work out okay. I want to welcome everyone. My name is Mark O'Rourke. I'm a co-chair of the Palliative End-of-Life Care Committee, along with Dr. Robert Krauss and Dr. Marie Bakaitis, and we will be each presenting different parts of our program today. As we go through this, we'd like to ask you to use the chat line for questions, and you're welcome to do that. There's also a Q&A, and we'll look for that, but maybe not as well. So for clarity, please use the chat, and please address your questions to everyone so that the panelists and the participants and attendees can all see it. So use the chat, questions to everyone. Welcome to our program. Our committee is in its first year of life, but we have a full agenda today, and we're delighted to have everyone here. We always begin our meetings with updates from the liaisons, and that would be Valerie Frazier, and I'm afraid she's having trouble getting in. Is that still the case?
Yes, I'm still working with her.
Okay, so we'll I'm going to then move on to another event that's been part of our program. Dr. Marie Bakaitis has done a attendee check-in with our last session that was quite well received. And so I will introduce Dr. Marie Bakaitis from the University of Alabama and ask her to check in with people given the experiences we've had in the last year. Marie, are you coming through? Are we getting well?
Oh, there you go.
Okay.
Sorry.
Next slide for her.
Yeah, thanks, Mark. And could you go advance to the next slide and probably the one after that? Keep going. One more. Thank you. So we have had a great response to, it's actually our second or third time, probably second time that we're doing our check-in. And so we've asked a few people in advance to just give us a 2-minute or so perceptions from the field about the positive and negative impacts on you, your patients, caregivers, and cancer practices from all that we're experiencing these days, continuing from COVID-19, but also the picture of social injustices. Again, this week, there have been many major events that are hitting all of our lives. And so Christy Klipko, I've asked in advance for folks to comment. So Christy, do you mind getting us started?
Sure. Well, I'm Christy Klipko, and I'm the protocol coordinator for the committee. And some of the things that I've found that have been positive from a work environment is, for one, I see the evolution of telehealth really taking shape across our cancer protocols, and that has definitely been an advantage of COVID. And hopefully this is going to go forward for just as a practice for cancer patients. And it's also, I've primarily worked from home since the onset of COVID, and that has certainly brought some of its challenges, starting out moving my computer into the laundry room and then around the house, and now coming to where I am now. And it's I would say that it's allowed for a little bit more flexibility with my family, and just what a great organization that we work for to allow us this kind of flexibility. And then in terms of maintaining resilience and hope, I would also say that COVID has brought out the best and the worst in people, and that for those of us that look for a positive way of reacting to that, it's helped us to make changes that in both our personal and work lives that hopefully are going to carry us forward in a new way. I find that it's oftentimes through diversity and challenges that we do some of our best work. So I'm thankful for what's yet going to come that we'll see in the next 3 to 5 years post-COVID.
Thanks so much,
Thank
Christy. Dr. Agarwal, do you mind commenting for us?
Sure. Thanks so much, Dr. Prakaitis. So I think, from my experience over the last year, it's been a mix of both positive and negative experiences in caring for cancer patients and also in caring for myself. And I think, when I looked at the second question of strategies to maintain resilience and hope, it's not just the strategies that we provide for ourselves, but it's also the strategies that we hope to, pass along to patients and caregivers, resilience and hope. And one of those strategies that I've tried to implement in practice is really, emphasizing the role of self-forgiveness. I think as an academic oncologist and caring for patients and family members, that we always have to be somewhat self-forgiving in a way, and it's important for patients and family members to also feel that way. I think, with this endemic that we're facing, it feels like life can be restrictive in a way. And so emphasizing this ability to forgive oneself and to forgive others, and to kind of celebrate life in the best way that we can has been unifying, at least, among my healthcare team and my patients and my patients' caregivers. So that's been, probably my biggest reflection that I've tried to practice on my own, and what I try to encourage my patients to practice is this concept of not keeping so much pressure day to day, which is very hard, but to really, trying to live in the moment and remembering, that the world that we live in right now is so different than just a year ago, and it's okay to feel how you feel on any given day.
Thanks, Dr. Agarwal. Appreciate the comments. Dr. Korn?
Hey, well, hi everyone, and thank you so much, Marie, for inviting me to also share some thoughts. My experience has been to observe a spillover effect from patients with cancer to society at large, and it's been very encouraging, and I'd like to tell you about that. This endemic, of course, refers to these co-occurring epidemics, and I think another epidemic that's been sort of unveiled for all of us has been the epidemic of loneliness. Loneliness can devastate people. And through an organization that I started with my wife, Devora, called Life's Door, we've been working on sharing with cancer patients and providers some of the techniques that you'll hear about later in this plenary about hope enhancement. And you'll hear there's been a progressive cone down to make the workshops more palatable. Well, we've coned it down further, and we've developed about a 45-minute training to allow volunteers to use simple telephone to reach out mostly to the elderly. We've trained in the last year over 900 volunteers who are people who are either furloughed or simply became unemployed, which is potentially demoralizing. and taught them how to use some simple prompts to make people more hopeful. And we've reached out to over 4,000 elderly individuals in nursing homes doing this. And it's amazing what an impact this has to define goals with these people. It's generally done on Friday afternoons, where there's a tradition in Israel of candlelighting, whether you're religious or not, before the Sabbath comes in. About 90% of the population does this. And we've tied it into that and had many, many conversations where you just prompt somebody to say, well, have you shared a recipe with your daughter-in-law, or have you read a book to your grandchild? And one particular individual stands out. This is a soldier who also enrolled in our volunteer program. And she decided that she wanted to reach out, albeit she's a soldier in the Israeli Defense Force, to Palestinian neighbors. And she's conducted her own hope workshops with them and has explored the issues of despair among various populations. Last week, I'm going to conclude with this, was the 73rd Independence Day in the State of Israel. And every year there are 7 volunteer awards that are given out. And this soldier, Sergeant Shaked, received one of the volunteer awards on the national level because of this effort. And we found it to be very inspiring.
That is very hopeful and inspiring. Ben, thank you so much. Dr. Crew.
Hi, I'm Kathy Crew. I'm a breast medical oncologist at Columbia here in New York City. And we've definitely had our trials and tribulations over the past year with Zoom fatigue and dealing with remote learning with the kids. But I'd like to highlight a couple of what I think are inspiring moments in spite of all of the adversity over the past year. So in the spring of last year was sort of the height of the pandemic in New York City, where we've had to deal with all the stresses in the clinical setting. But I guess in the late spring, around 7 p.m. every night in the city, there would be all of these cars honking their horns, all these people cheering and clapping and even banging pots outside of their apartment windows while they were supposed to isolate, just to sort of cheer all of the frontline workers, which I found very inspiring. And so I made a point to go walk my dog every night just to hear all the crowds cheering. And then the other more inspiring moment more recently is, so we started the COVID vaccine rollout at our institution here in Washington Heights. There's this large track and field center just across the street from the hospital where we try to, we were vaccinating over 2,500 people per day. And there are some of these, elderly folks who are, traveling hours to come get vaccinated. And I do think they made a very concerted effort to vaccinate a lot of the underrepresented minorities in Upper Manhattan, the South Bronx, Harlem, to really try to get the word out, because we know that these are the vulnerable populations that are most affected by COVID. So I found that to be really inspiring as well.
Thanks so much. Dr. Chung, last but not least.
Hi, everyone. Yeah, so this last year was just a very interesting year because, it just had such an impact in terms of not only our patients, but, our own physical, mental health. And, going down and kind of breaking this up into looking at the positive and negative effects, of COVID-19 over the last year. One of the, just probably start out with the negative so we can kind of end with the positive. The negative impact was really, of course, all of us being really social beings. It was really hard with the isolation. And initially with the lockdowns, it was just tough because being in your home and, being away from all your colleagues and all your friends, it was just really challenging. And I think this is really hard on our patients because not only were they really fearful of the potential, possibility that they might, go to a hospital and then contract COVID-19, which ended up, potentially delaying some of their care because some patients were just, really concerned about going to a hospital. It was actually very difficult for them, for instance, when they actually would come to the hospital and you're talking to them about a new diagnosis of cancer and because of the visitor policies, they were not allowed to bring any family members into the hospital, to the clinic. So they were there by themselves, actually really, hearing about, a new diagnosis of pancreatic cancer or some other, serious medical illness. And that's really difficult because, when they're, discussing this with their physicians, I mean, they need the support, they need the emotional support, they need, their family members to be there. And it really, goes a long way in terms of helping them through the situation. Now, thinking about some other negative aspects of this, the COVID-19 pandemic, one of the things which is actually a plus and a minus for me was that, technologically, we've grown quite a bit over the last year. The world has become a very, very small place. So you can actually have meetings at all hours of the day with all your colleagues around the world. And it got to be really challenging because, the earliest meeting I had was like 5 a.m. And, they're scheduling meetings like 7 p.m. because, you'd have a colleague around the world that you wanted to actually have these meetings. And normally we would actually have these meetings for these clinical trials, maybe like once or twice per year where you all get together. And it's nice because you get to socialize, you get to meet people. But when you're doing it on Zoom, they started having these meetings more frequently, which meant that, you're constantly on a meeting. So you would literally go like an entire day from morning to night, jumping from meeting to meeting. And sometimes you'd have 2 meetings at one time where you'd have to join because you're like a, important PI of the study, so you need to actually give your update. So you would literally be sitting there with 2 screens, going on simultaneously, and you're actually trying to make sure you're in the right mindset when you're in the right meeting and trying to, get through all that. And then you still had to write your papers, do your proposals, clinical trials, et cetera. So it actually added a lot more work, which was a lot more stress. So that was a positive and a negative because it made you really productive, but it also really kind of burnt you out during that time. But, thinking about some of the positive aspects in terms of, what's happened over the last year, I mean, I think that, this really helped both the physician as well as the patient. Telehealth really became mainstream. So, when Medicare actually started reimbursing for telehealth visits, patients were really appreciative of the fact that, you could actually have a toxicity check with them being at home with their family, being there to be supportive. And you could actually, do these meetings. I actually ran a clinic one day on a Sunday, just because my week was just really busy. So I just actually made a clinic on a Sunday. And the patients were just really appreciative because they were just much more comfortable at home. And I think that was actually a big plus. So I think that, going forward, this is going to be potentially game changing, especially if Medicare continues to, support telehealth as well as the private payers. This could really definitely change, medicine going forward. Another positive aspect of telehealth was that, patients are constantly seeking like opinions across the United States. And when they actually allowed, emergency exemptions for medical license across state lines, this allowed, patients to not have to travel, but then they could actually end up, setting up a telehealth appointment with you if again, the state that they're in allows it. To have a second opinion. And I saw, some of patients would go to my other colleagues across the East Coast get opinions, and, some of the East Coast people would come and see me and get opinions. And it was actually kind of nice because it made the world a much smaller place and they didn't have to travel. And I think it really does help to promote better healthcare for our patients. So I think that was actually really, really critical. And I think that could really change, things going forward. And finally,
Oh, go ahead.
and finally, in terms of like strategies to maintain the resilience and hope, I mean, this is where it goes back to technology, because, we had Zoom happy hours, we had Zoom birthday parties. It was actually kind of fun because, you get everyone together on screen, you're actually over there just reminiscing. So technology was actually a really good thing from that perspective, because it did, again, make the world a much smaller place. YouTube really got me through a lot because I never watched YouTube until the pandemic. But on YouTube, you could find many different things to do. For instance, like I started baking bread when yeast and flour was available at Costco again. So I started to learn and take up new things, which I thought was actually really helpful for me in terms of getting through this. And I think this is a real blessing for me, was that in terms of my practice, I mean, going to work and taking care of patients, I mean, that was really critical in terms of being able to get through this, because I wasn't at home like many other people that of course were in the service industry where they were not able to go out, but going to work and having a purpose and really taking care of patients actually had a tremendous impact in terms of getting through and maintaining hope throughout this entire time. And patients were really appreciative to see us actually going to work during this time, which was actually something that, prior to this, they didn't express as often. But during the pandemic, I mean, you'd hear that a lot. They would come in saying, it's like, thank you so much for, coming in, doing your great work, et cetera. So it was really nice to actually hear that and see.
Vincent, thank you so much for sharing, and to all of our volunteers who just have shared insights that I think are common to most of us. It's been very positive. Thank you. Mark, let me turn it over to you, back to you. And I think, is Valerie able to, we should go back a slide, please.
If we can. And Valerie, did you make it on the call?
Yes, I'm on by audio. I guess they can't get me on video.
Oh, I'm sorry, but please give us your update, and we'll we want to hear what's going on.
Okay. Well, you'll see my slide up there, and I just wanted to introduce myself. I'm Valerie. I'm the lead palliative end-of-life care advocate, and I'm thrilled and honored to work with this important committee with Mark and Robert and Maria and so many others of the dedicated investigators and advocates. This committee's research is pivotal in helping to advance quality supportive care for cancer patients and for their caregivers, especially during the most critical times of their illness. And as we've all experienced over the past year during the COVID pandemic, it has now become even more critical for cancer patients as they try to navigate difficult treatment and care decision-making. After my own advanced cancer diagnosis 14 years ago, and having lost both my parents and several other relatives to cancer, I was compelled to make a difference for patients through research and research advocacy. And I continue this work with SWOG and many other cancer organizations to support and lead research that's important for patients nationally and internationally. And you'll see on the following slide that I'm going to introduce this committee's strong team of advocates who each bring their extensive patient and advocacy experience and expertise to the research planning table. Lee Jones is the lead advocate for the Survivorship Committee, as well as being very active in this committee. Lee has been an advocate on the S1820 from its early beginnings in the Survivorship Committee. And he has had early input into the HOPE concepts as well. He is a survivor of stage 4 colon cancer and a research advocate on many levels in his state of Virginia. And then Carol is the lead advocate on the GI committee, as well as being very active on this committee. She's participated in the S2016 trial, the ACCEPT group, the PALCare pancreatic, and she's provided early input into the hopefulness intervention and provider communication and in the intimacy planning. Carol's husband lost his life to pancreatic cancer, which led her to become a research advocate and being involved in her state of Massachusetts and nationally. So I hope you'll take a few minutes to learn more about the many advocates with SWOG through their bios and clicking through the SWOG network link on the SWOG website. You'll find more details about our work right there and how involved we are both within SWOG and outside of SWOG. So thank you for letting me talk today.
Well, very good, Valerie, and thank you. And we've put you in a lot of time in the regular committee meetings and all the subcommittees. Marie, I'll let you introduce our next speaker.
Absolutely. So I am super excited to introduce our plenary speaker. Could we go another? Yay! Yes. So I almost feel like saying this individual needs no introduction. So I will definitely introduce Dr. Robert Krauss, who, as you see on the slide here, is a professor of surgery at the University of Pennsylvania and has been a co-chair, my fellow co-chair for this new committee. However, he is no new person to SWOG. And so, Robert, I know I wouldn't get all of those activities correct. So I'm going to let you share those further. But it's my great pleasure to say that this is our first completed SWOG trial within the Palliative and End of Life Committee. And so this is a momentous occasion for us to hear the results and celebrate. You know, there's only one first, and that would be you, Dr. Krauss. So take it away.
All right, well, thank you. So I appreciate the opportunity to tell everybody a bit more about S1316. You've been hearing me talk about it for a while now. It was with me when I was in the survivorship committee and came to our new palliative end of life care committee. And so I'm going to give about a 20-year experience in about 25 minutes. So I'm going to run. So next slide. So the disclosures I have is I got a lot of help with this talk. These people, Mary Wagner, Octavia Bojorquez, Matt Rock, helped me tremendously with the different slides I'll be showing. And Katie Arnold helped crunch a lot of the numbers, and the study could not have happened without her. Next slide. So I just want to start out with a patient, and those of you who are experienced with this problem, malignant bowel obstruction, may have seen patients like this, and those who have not. This was a gentleman, 7 years old, had a history of a rectal cancer, had an abdominal peritoneal resection. He went on to have recurrent disease and had peritoneal implants. And then he was admitted for signs and symptoms of a small bowel obstruction. And so you can see the air fluid levels there. Below some of those distended loops, you can see a non-distended loop below it. And then you can see in the pelvis, there's a lot of tumor. You can see other signs above where there's nodularity, that's carcinomatosis. And so this gentleman had a malignant bowel obstruction. The question is what to do about it. Next slide. So very briefly, it's of the palliative care issues that we deal with. It's relatively common. It's about 43% of surgical consults that was seen at MD Anderson, and most of those are small bowel obstructions. And then as far as the primary cancers that we see at most, it's probably most common incidence in ovarian cancer, but because colorectal is much more prevalent, it's probably more commonly seen in that disease. But those are the two most common types of cancer that we see this problem. And then there's a whole host of others. And then rarely we can see a non-intraperitoneal primary. Next slide. So I'll thank Jeff Sloan for this picture. This is how we think a lot. So there really is no defined algorithm for care of many patients. You have a patient like I showed, and really a lot of time you feel you're damned if you do, you're damned if you don't. What is the right treatment for this man to make him relieve his bowel obstruction and not harm him? Next slide. So also at MD Anderson, Dr. Badgewell looked, and so for patients with small bowel, they consult the surgeon for a small bowel, malignant bowel obstruction, and ultimately surgery only occurred in about a quarter of the patients. And then there was IR procedures, PEG tubes, and often non-surgical management. Next slide. So this was a paper from Dr. Foyer back in 1999. He did a large review of small bowel malignant bowel obstruction in gynecology. And he came out with a conclusion that to continue improving the care of our patients in this most difficult of setting, more prospective research is needed on more patients across many different settings and using similar outcomes to assess effectiveness. Carrying out a multi-center study should be the way forward. And in the rebuttal to this, Dr. Rubin wrote, while their call for prospective multi-center trials is certainly laudable, it's unlikely to be fulfilled. We took that as a call that we really could do a study like this, although it would be difficult. Next slide. So years ago, we had an international conference on malignant bowel obstruction back in 2004. And there was two purposes. One is we wanted to use malignant bowel obstruction as a model to look at all the issues related to implementing a prospective study for patients with advanced cancer. And then we also wanted to come away with a randomized trial for patients with malignant bowel obstruction. Next slide. And so we had about 50 people participated. People at the front you can see were panelists, Jeff Sloan and Marcia Grant. You can see they've been part of the study since the inception. You can see me, I'm looking down at something. That's not an iPhone. That was the clicker for the slides. I don't think they had iPhones at the time. Next slide. And you know, in addition, we were able to meet and talk and discuss and debate about how to go about such an undertaking. Just to show you, the two people talking in the back, that's Dr. Foyer and Dr. Mercadante. Dr. Mercadante especially has published quite a bit on this subject. He's from Sicily, and that allowed us to call it an international conference. You can see Patty Gantz there, who many of you know, as well as Marcia Grant. Next slide. And we have, this is one of the things that came out of it. We have this supplement, and I'm showing this. If anybody wants it, please email me. I still have several left, and I'll send it right out to you. Next slide. One of the products we did come out was a clear definition of this problem, which we used on this study. And there really wasn't in the literature, and this has been used by a lot of well-referenced, the FDA has used it, et cetera. So malignant bowel obstruction has to have clear clinical evidence of a bowel obstruction, history, physical, and radiographic. It has to be beyond the ligament trite. So we're not dealing with gastric outlet obstruction. It starts in the jejunum. And so for intra-abdominal primary cancers with incurable disease and a bowel obstruction, those people were considered a malignant bowel obstruction, even if you couldn't see necessarily a bowel obstruction due to disease. The reason why we did that is because many of the reports for how you treat malignant bowel obstruction excluded those patients if they had an operation, and only then could you know if they had an operation due to clearly cancer. So anybody who essentially has advanced cancer and a bowel obstruction was included. But if you had a non-intraperitoneal disease, you had to have clear disease in the abdomen. All right, next. And so this was the algorithm that we designed, and it's led to ultimately the study we did. It was mainly a randomized study, but we had a non-randomized or observational component to really augment the randomization. Next slide. And then I sort of took it on the road. And so basically the white are all the grants that we submitted, and the red are the talks, many of the talks that I gave, and I and others, and trying to promote this trial and the different cooperative groups. Of course, there's been consolidation of cooperative groups since that time, grand rounds, etc. Ultimately, until 2011, when we decided to make it a comparative effectiveness study, observation only, we submitted to AHRQ and got well scored but not funded. And then ultimately what we did is we, based on Garnet Anderson getting involved, and then we partnered with SWOG did we then also add a randomized component, which I'll show you in a moment. Next slide. So basically, this study is a partnership, and it's been mentioned before, and you know that for many SWOG studies, we need to seek other funding, and this study was partially funded by AHRQ, and these are the investigator team. You can see that Garnet Anderson and is a co-investigator, Marcia Grant and Jeff Sloan are consultants throughout the study, and then our SWOG team. Originally, one of the co-study chair was Dr. Badgewell from MD Anderson, but Dr. Deneve eventually became the co-chair. Our nursing chair has been Virginia Sun. We have a non-SWOG investigator, NCTN investigators, Dr. Secord from Duke. Statistics lead has been Katie Arnold throughout the entire study. And then Roxanne Tapasio has been our data coordinator and has helped immeasurably. Next. And so this was the final schema. And so basically it's undergone a couple revisions, but this was the final. The end that we targeted was 220. We ultimately accrued 221 on the final day. We accrued 2 on the same day. And then the goal was originally 50, which I'll show in the randomized, it became 55. And these were our final numbers in red. Next. And so our primary endpoint was novel, and that it was good days out of the hospital, that most patients facing the end of life would prefer to be at home as a primary outcome measure, and of course being alive as a good day. And then with multiple secondary outpoints, days without an NG is well published. Days eating, the Arizona Cancer Center, Cindy Thompson led that. Health-related quality of life, MD Anderson Symptom Inventory, and also the EQ-5D. And then morbidity, mortality, and survival. Next. And so every patient who was accrued to the study had to pass a test, because the randomized arm and the observation arm had to be as much the same as possible. So every patient had to be a surgical candidate, somebody that you thought an operation might help and they would tolerate it. And that there was equipoise, not necessarily that you didn't maybe think one arm would be better or one treatment approach, but you thought it was reasonable to treat either surgery or medical. Next. So the basic eligibility criteria had to have the criteria outlined in malignant bowel obstruction. Intra-abdominal couldn't be an emergency procedure. There had to be decision-making and a reasonable performance status the week prior to admission. Next. And this is the basic timeline to accrual. So basically the patient had to be seen and deemed surgically eligible. There was 3 days after that was determined to registration. And once they were registered, there was up to 2 working days to actually do the whatever the intervention was. So if they were going to have an operation, they had to have it within 2 working days. And then somatostatin or somatostatin analog or octreotide was originally a mandate of the study. It became recommended, and I'll explain why. If someone had been on multiple days of it, they were not eligible because that was deemed treatment. This was ultimately a pragmatic trial once somebody was registered. So we recognize that somebody who may have randomized or chosen surgery may ultimately get better and then not get an operation, and somebody who was on a medical arm may ultimately get an operation, and I'll show that's exactly what happened. Next. And so this will look like for a year. Patient would be followed for 13 weeks, 90 days, 91 days on weekly phone calls once they were discharged, mainly asking the questions, primary outcome, were you in the hospital? And then ultimately trying to get other data such as their quality of life questions. And then after that, monthly up until 1 year. Next. So our analysis plan depended on the 2 components. And so inference is based on the assigned treatment. So if you're randomized, we use the randomized treatment and intent to treat. As I said, it's a pragmatic trial. Even if you were intended to get surgery and didn't get surgery, you were on the surgery arm. And then the non-randomized component is using the initially chosen treatment for a pseudo-intent to treat. Next. And so these are their accrual sites, and I want to get at least one slide just showing all the different investigators, site PIs, and there's many people that were involved in each one of these sites, and to thank for their hard work to get their patients on this trial. There was, I highlight the original sites. There was, as you can see, our top 2 sites were not considered. Originally, I didn't know the people there, and eventually they were and became great accruers. Next. And so this is what happened. And so basically, HRQ funded us in September of 2013. It took about 1.5 years to get the study opened. And then you see the red is the many talks I ran rounds, going to the different cooperative groups, trying to get going at a lot of the different meetings and giving short updates, etc. Over the years. And finally, we completed accrual almost 1 year ago to the day. And now we are undergoing analysis. Next. And so what are some of the challenges we face, and how did we learned a lot. And so first of all, some sites were very slow to open. We had no central IRB at the time. And so basically, very early on, we decided we needed to have more sites, and we started reaching out early on in the study to, and of course that was an amendment, to add sites. The first patient, we were English only speaking, and the first patient that was eligible, the University of Arizona, was a Spanish only speaker. And we recognized we better open up to Spanish, and our quality of life instruments were also validated in Spanish. The Dietary Recall Center, they spoke Spanish, and so we quickly realized that and then added Spanish only speakers, which was great, because then the next thing was trying to get our Latin American sites involved. And I can give a whole talk on that one. And basically there was a lot of hurdles, but we were patient, and it ended up working out quite well for us to that all of our Latin American sites that were at the time, there are more now, but Mexico, Colombia, and Peru all were able to put patients on. We expanded. One of the questions that came up, well, what about if I have an esophageal cancer and the patient has a malignant bowel obstruction? We needed to clarify that it didn't just have to be intraperitoneal, it could be all GI tumors. There was difficulty involved getting somatostatin analogs. It was impossible in South America, so we made it recommended and not required. We had to deal a lot with clinician bias, and so that's where the constant education, and we are, especially with Dr. Deneve and Dr. Deutsch, who reached out to many of the sites to help how to put patients on, to put their bias aside. We wrote a paper about it. Dr. Deutsch was the first author. Patient bias taught us that for this trial, there needed to be you had to invest a lot of time into discussing it with the patient, and often you had to come back multiple times. There was concern for when patients were first seen, were they really operative candidates? And this is where there's a lot of different specialties, especially treat patients slightly differently. And so basically, it wasn't when the surgical team first saw the patient, it was when they felt the patient was surgically eligible. That was another amendment. And then lastly, we completed accrual non-randomized arms, and we recognized we weren't going to get to our randomized component unless we started closing them, which we did. And I was very fearful at the time. This is where Katie Arnold thought we should have closed it earlier, and she was ultimately right. And I was fearful that the study would have died. But ultimately, we were able to then just focus more on the randomized component and accrue. So the next slide. And this shows how we accrued over time. The green, as you can see, is the patient choice non-surgical. That was the first one that we basically, it accrued to about 165, and we ended that in 2018. And that took it took a while for us to get back to accruing again because we had to sort of go through a whole process and stop accruing for a little while. Then we stopped the patient choice surgery arm, as you can see, and then completed only the blue, which is the randomized surgery, and ultimately, or the blue and the white are the randomized arms, and ultimately you can see we were able to focus on randomization and complete the trial. Next. So I got that from Roxanne. It was a nice gift when we completed our accrual, and it was a big day. Next. So I've shown this before, but just to reiterate, the top accruers were University of Tennessee in Memphis, Northwell Health, tremendous teams there. Banner, University of Arizona, where I used to be, University of Kansas, and then you can see down the line the other sites that put patients on the study. Next. But this is who could randomize, and this is, as you can see, it's clear, you know, our Latin American colleagues were able to augment the study tremendously, as some of the highest accruers on the randomized, and they started much later. As I said, it took a while to get them on, but once they did, they were able to. Some of these sites, the only patient they put in the study was randomized, like Loma Linda and Baylor and Houston. And Dr. Quitano at the University Hospital, which is in San Antonio, was able to randomize 2 patients. Next. And so a few things to go over. First of all, so I put the randomized, we combined them for this study of demographics, and the observational surgery, observation and medical. And you can see that our age is really the same across the board, as well as the gender mix in all the groups. We did really well as far as our ability to put Black patients on this study, which we're very proud of, including on the randomized component. We did well, as you can see, with Hispanics, more on the randomized, and that's because of our Latin American colleagues. And the next, you can see that Latin American only put patients on the randomized arm. There is some difference as far as physician specialty, in that more of the randomized patients and more of the surgical patients were surgical oncologists and not gynecological oncologists. Some practice differences presumptively there. And we're going to be looking at that as we look at the data. Next. Clinical features. So first of all, in the randomized arm, there are more gynecologic primary cancers. And there also are more in, as you can see, in the observational medical. But as far as patient sort of overall clinical, they're pretty similar. The albumin, sort of a sense of how sick people were nutritionally, BMI, ascites, carcinomatosis, all of those are essentially about the same. The performance status is very close with the observational arms. Slight difference in the randomized arm, where we have a little, several more zeros and twos. Next. What about some outcomes? Now, this is the index hospitalization, and we see that for the days in the hospital from registration, we can see that there's seems to be lower hospital days in the observational medical group. Days with an NG2, once again, that's been widely seen in the quote in the literature regarding treatments, and there seems to be somewhat less in the observational medical arm. It's hard to know why, and so whether that holds up with our when we model, we'll see. but at least that's the way the data is unadjusted. And very few patients died on the original hospitalization. Next. And so this slide is where, first of all, the first line of surgery shows where it's a pragmatic trial, which I showed. And so basically, as you can see, for the randomized surgical, some didn't get surgery, just as in the observational surgery. And with the randomized medical, some did get surgery, whether observational or randomized. But as you look at the steroids, octreotide, PEG, and NG, you will see that the randomized surgery and the observational surgery are very close, as is the randomized medical and the observational medical. Next. So a few assumptions of what happened. Basically, we originally were going to register 200 with 50 randomized. We increased that. DCP thankfully allowed us. Dr. Parker was instrumental, and we accrued 221 patients, 56 randomized. We were under the assumption that median survival would be 3 months, and we were very close. It was 3.2 months. Good days, we made the assumption of 33 days. Ultimately, it was a little longer at 49 days. Next. And survival, now this is unadjusted and it's just very gross. We're looking at patient choice, which is the blue, randomized is the red. And you can see overall that the randomized arm has lower survival, at least in this unadjusted, non-modeled, etc. survival. Why is that? It's sort of it's opposite of what you may think. You may think that the patient choice arm would actually be sicker and have lower survival. So we're going to wait and see what the data tells us as we adjust and look at this through different modeling techniques. Next. Now, one of the big difficulties with a study like this, of course, is missing data. And so you can see this with the ability to eat. And this is trying to get data from these patients. The upper is the surgery arms combined, and the lower is the medical arms combined. The dark pink is patients that died. So obviously that has a huge implication in data, getting data. The dark orange is patients that refused any more follow-up. The orange, the lighter orange is patients that we just couldn't get the data. And the light blue is data that we were able to get. And so you can see that the missing data will be, does make in a study like this difficult in analysis and something that needs to be taken into account. I will say we're also proud about how much data we were able to get in a sick patient population. Next. And then with MD Anderson, once again, you can see that the dark pink is patients that died, dark yellow is patients we couldn't obtain data. And so as you can see, we had decreasing data acquisition over time. This is to the 13-week endpoint. Although we were able to acquire a tremendous amount of data, this did, as could be foreseen, decrease over time the amount of data we got. And of course, that will play out in how we analyze the data and what it looks like. So next slide. So here's health-related quality of life, MD Anderson Symptom Inventory. For the symptom inventory, you can see there's total symptom severity on the left. On the right is interference with life. Those are the two main domains. And what we did for this slide is we reversed it, just so you know. Typically, quality of life is the higher the numbers is increased, and that's why I decided to do this for this presentation. Although for the MD Anderson Symptom Inventory, 10 is actually a worse quality of life. So as you can look for the average scores, quality of life actually seems to improve over time. Well, that may make sense because these patients are living longer and ultimately doing okay. But then if you impute a patient, worst case scenario, a patient dies, a worse quality of life score, you can see, of course, things go down. Is there a difference between the groups? It's hard to say based on this survey or this graph. The middle case is when we averaged missing data, and it sort of smooths out the curve, and you can see maybe there's an implication that the surgery group, the patient choice surgery group, may be slightly higher. We'll have to wait and see. Next slide. So there's a lot we have left to do. So first of all, Garnet and Katie and the team using different modeling strategies to control for differences in good days and health-related quality of life, survival, and other surrogate endpoints is where sort of the time is going to be spent looking at our endpoints right now. We're going to look at qualities, and that may show us something very interesting, patient preference, and Jeff Sloan will be integral in that analysis. We're also hoping to look, and we've agreed to, team and SWOG has agreed that we can also look at healthcare utilization. We have a lot of data related to hospital stay. We're looking at much more detail on the actual operations and medication use, et cetera. And finally, the long-term goal is that we will take ultimately what we learn and have an implementation strategies of the outcomes that we can then potentially have another future study to use what we found that we can actually change care for patients who suffer from this problem. So I hope I didn't go too far over, but thank you.
Robert, thank you very much for a wonderful talk, and congratulations on an extraordinary marathon effort to complete SWOG 1316. It will go down in the annals of history. I encourage people to put their comments in the chat section for everyone, and we'll either respond individually or somehow. But I want to introduce our next speaker, Dr. David Feldman, and he's going to talk about hope. And he's a psychologist, the chairman of the department at Santa Clara University. We have drawn him into the SWOG world in the last 2 years, and we are benefiting from his ability with psychology, his methodology, and his expertise in this area of hope, which is important for patients and providers. Dr. Feldman and Dr. Korn have worked together and have done some surveys, and Dr. Feldman will be summarizing our work to date and talk about things coming up. Dave, go ahead and take it away.
Thank you very much, Mark. I really appreciate that. Hopefully everyone can hear me okay. I had a little technical difficulty, so I'm on a different computer than usual. So I'm glad to see that things are working now. And I will be joined, we will be sort of tag teaming here, myself and Dr. Korn, in presenting this research. And I'll start out here. Thanks for inviting us to talk about this. You all have heard us talk about hope before, but in the past presentation, it's really been about writing you a promissory note and talking about what we were going to do. Well, now we're going to talk about what we have found over the research that we've done during the past year or two, and also point the way towards a future-focused research agenda as well, and even invite you all. Hopefully some of you will want to get involved in this research in various ways, because we really do believe that hope is an important and under-researched topic. And we hope that more people want to get involved in investigating it. So please go to the next slide. Hit next one more time. And of course, the first thing that we need to do whenever we're talking about hope or similar kind of psychosocial constructs is to really carefully operationalize them and talk about how we're going to measure them. Fortunately, there is a model of hope that's been around for about 30 years in the social science literature known as hope theory, which has birthed a variety of valid and reliable measures, including the adult hope scale, which is a quantitative self-report measure that we're going to be referring to a lot today. Hit next once, please. And just briefly, the model, the hope theory model, defines hope as consisting of three interrelated components. And these were originally called the three components of hope. I think an intuitive way of getting your mind around them is to think of them as the three conditions for hope to thrive, because it turns out that people who have these conditions set in their lives tend to report higher levels of felt hopefulness, but also all kinds of other positive outcomes. And I just want to briefly summarize what these components are about. Next slide, please. So here's you, or perhaps it can be anyone that you know. It can be a patient, it can be someone that you love or care about. And I'm just going to talk about how these three conditions for hope to thrive relate to the individual. So click next. So the first condition for hope to thrive is having goals. So having something to hope for. And goals can be anything in our lives that we want to get, be, do, experience, accomplish, really in any area of our life. And of course, when we think about medical patients, particularly those early in the disease trajectory, the goals that we're going to hear as healthcare providers are often things like cure or life prolongation. But goals can also be further on in the disease trajectory, quality of life goals, right? Goals to do or see something one last time, to go to the beach one last time. I know in some research that we did on goals in patients in hospice, I remember I interviewed one particular fellow who said that his hope, his goal was to repair the ancient tube radio that was in his garage so he could give it as a gift to his grandchildren before he passed away. And so really goals can run the gamut. The important thing for hope really is to have at least one goal in life that is meaningful, that is intrinsically meaningful. And of course, the second condition for hope to thrive, please click next, is this, pathways. Pathways is the perception that a way exists to get to your goals, to get from where you are to your goals. And if you've ever had a time in your life when you have had a goal that was important to you, but you could not think of a way to get there, you probably didn't feel very hopeful at that moment. And so that really highlights the importance of pathways. And of course, we as healthcare professionals are often sources of pathways for the patients and for the families that we serve. We call those pathways treatments. But of course, people can have all kinds of idiosyncratic pathways in their lives, for their own unique goals as well. Please click next one more time. And the last component of hope is agency. And agency is kind of a strange word, but it basically means energy or motivation, the motivation necessary to pursue goals, because this process takes motivation, and that can come from many sources. It can be physical energy from an appropriate diet, sleep, exercise. It can be energy that people sometimes report getting from spirituality, their spiritual practices and beliefs. It can be from interpersonal relationships, those cheerleaders in our life that encourage us towards our goals. It can also be agency that comes from our personal beliefs about our own capabilities. But the important thing here for this model is to know that these three components or conditions, when people have them in their lives, they tend to report much higher senses of felt hope and also all kinds of other positive outcomes. Please click next. And this is a graphic, fairly hot off the press, from an article that was published about 5 months ago in the 20th anniversary issue of the Lancet Oncology, titled The Science of Hope, by myself, Dr. Korn, and Dr. Wexler. And this diagram you can see at the center is goals, pathways, and agency, really talks about the inputs and the outputs, the causes and the consequences or outcomes of hopefulness. And next slide, please. And I will attempt to summarize 30 years of research in about 2 minutes to give you a sense of where we've been and what we know so far about hope, that will then set the stage for us giving you a sense of where the kind of research that we've done in the last year or so and where we'd like to go with this research agenda. So we know that people who have higher hope, as defined by goals, pathways, and agency, have lower depression and lower anxiety. They have greater psychosocial resilience following trauma. People with higher hope report greater cardiovascular health promoting behaviors, including greater chances of being a non-smoker, a non-drinker, eating a lower salt and fat diet, exercising more regularly, visiting the physician for regular checkups, etc. Better coping and functional outcomes in chronic pain. And there's a number of studies that show that people who have conditions that generally cause chronic pain, that if they have these three components of hope in their lives, so they are high hope individuals, they tend to report the pain as less painful, but also they tend to cope better and have greater functioning in their life despite the pain. They have greater adherence to rehabilitation regimens, and perhaps most importantly for us here, better coping and more effective identification of treatment strategies for a variety of cancers, including breast cancer, prostate cancer, and pulmonary cancer. And the research is limited in this regard. There's only a few studies. And so this really gives us a sense of where we'd like to go with this research agenda, which we'll talk about a little later in the presentation. Next, please. And there's also some indication, and this really gets to what we've been doing during the last year, year and a half, that hope may be related to survival in patients with advanced cancer. So you all are familiar, I'm sure, with the amazing ENABLE research that our very own Dr. Marie Bakaitis has done. And ENABLE is, of course, an early palliative care intervention, which has done all kinds of wonderful things for the world and has birthed all kinds of great research. But what we've done with the collaboration of Dr. Bakaitis is to look at the ENABLE-2 and ENABLE-3 data sets and to reanalyze them, looking at the relationship between hopefulness and survival in these 529 patients with advanced cancers. And what we were able to do was to identify 3 items in the existing data set, 2 from the FACIT-PAL and 1 from the CESD, which is a depression scale, which explicitly measure hope, and make a hope index, and then take a look at the relationship between that and survival in this data set. Next, please. And I guess I'll let the curves speak for themselves. You can see that the green group is the high hope, the blue group is the low hope. And you can see that the sweet spot is really about 15 months out. And so there is evidence here, at least preliminary evidence from reanalysis of this data set, that hope may be related to survival. And this really points the way again towards redoing this, but in a prospective way with a perhaps better measure of hopefulness. Click next. And hope not only has implications for patients, as we've really talked about, it also seems to have implications for healthcare professionals. So you've seen me talk about this data before. This was actually a survey that we did of 226 members, or excuse me, 224 members of SWOG, SWOG investigators, and you see the breakdown at the top. This has now been published, or at least is in press, in JCO Oncology Practice. And what we looked at was the relationship between burnout, hope, and satisfaction with life, or general well-being in you all as the population of providers. Please click next. And what we found is this, that hope mediates the relationship between burnout and life satisfaction, such that burnout is not directly impacting people's satisfaction with life or well-being among these providers. Instead, what's happening is burnout appears to erode hopefulness, which in turn then erodes general well-being. And this has real implications for how do you combat the effects of burnout on satisfaction with life. Perhaps one of the best ways of doing it is to offer a hope intervention, which we'll talk about a little bit later in this presentation. Next, please.
Okay, so that was great, Dave. And I'm in the next 9 or 10 minutes going to speak about what we're referring to as a double bind that comes up. In other words, this hope stuff sounds great, and yet there are certain barriers that I think we all face when considering our involvement in this kind of an endeavor. Next slide, please. So first, there is an equation which we sort of subconsciously create, and by we, I mean both providers and patients. Next slide. In other words, I'm very committed as an oncologist to cure. There's nothing I'd rather achieve than cure, especially if I can prolong survival. Oh, I think we're jumping. Yeah, stay right there, thanks. Especially if we can have survival that's endowed with a really high life quality. Now, there are certain problems with this, 2 of which, as much as we see encouraging data every January from the American Cancer Society about how we're doing with the frontier, there's still quite a few cancers, quite a few diseases that are not curable. What's more, the literature is fraught with debate as to how we define cure. So it could be that as a radiation oncologist, I would like to use the word cure for a patient, but maybe I have a hesitation because I think my surgeon or the medical oncologist who referred this patient to me wouldn't define cure the same way. So for this reason, I find myself not using hope even in the curative context. Next slide. So we're arguing that there's a reluctance to use the term hope, even when we mean hope for cure. Now, how can I give you another example of this? On the next slide, there we go. You'll see an article that we published about half a year ago in JNCI Cancer Spectrum. And we tried to get at the issue bibliometrically. And what we did, next slide, was to look at two high impact journals. Next slide, Journal of Clinical Oncology, as well as JAMA Oncology. And in both of these journals, over the last 20 years in the case of JCO, in the last decade or so in the case of JAMA Oncology, there have been consistently three genres of article. Next slide. First, there is primary research, the hardcore scientific data that we all love to present. Next, there are editorials, articles which try to contextualize the primary research that we like to publish. And finally, on the next slide, there are narrative pieces. And you'll agree with me, I think, that there is sort of a gradient in terms of the robustness of the data that's embedded in such articles. The most robust being the primary research, especially in high quality journals like these, less so in the editorials. And the fluffier piece is the narrative work. And on the next slide, you'll see that there's the kind of statistical significance that we all fantasize about when we looked exactly at that gradient. That's to say, as you proceed from primary research to editorial to narrative work, you see this dramatic trend where the fluffier the article, the more likely we are to use the term hope for cure. But in the primary research, that word hope, even in a curative context, just doesn't appear at all. We're reluctant to do it. This is a table in which we do it on the article level, and the reviewers asked us to do it on the sentence level, and the exact same trends reappeared. Next slide, please. But it's not just that we have a reluctance to use the term hope in a curative context. We're also, tragically, I would say, reluctant to use the term hope when we're not even shooting for cure. And this is because we ironically worry that we will create despair when we use hope this way. And the next slide gives you one example from the literature of this. These are data from the hematology group at the Dana-Farber in Boston. And in an article, which is really highly cited about end-of-life discussions, where clinicians were taught how to consider hope in a non-curative sense, you can see that by summating the blue, yellow, and gray bars, that the second greatest concern that clinicians had when they used hope in a non-curative context was that they would take away hope. So it's kind of like that Larson slide, that far slide that Dr. Krauss done before. It's this double bind. You're damned if you do, you're damned if you don't. And the outcome is we just don't use the term hope. And you can ask yourself as I'm speaking, how often do I use the term hope in my interaction with patients? And I'll bet it's not very frequently. And you can ask yourself how that might make a patient and a family member feel. Next slide, please. So how can we resolve the dilemma? And we're going to propose two concepts for resolving the dilemma. These are hypotheses, but we look forward to determining whether there's validity to them in the coming years, hopefully with SWOG. First, the idea of reintroducing authenticity. Next slide. Tom Smith, several years ago, ran this study where he got IRB approval to do hopefulness assessments by having patients fill out a classic hope scale before he conveyed bad news and after he conveyed bad news. And you can see from these bar graphs that there really was no difference before and after. And in reading the paper and querying the subjects, he found that this was because his group was able to approach the patients with authenticity. the patients perceived that these physicians and the staff were genuine, and trust developed. So this is certainly something that's noteworthy. And on the next slide, another population, which might even be more challenging, a population which I'm really not involved with at all, is the pediatric population. This is from a series of studies published in the JCO by Jennifer Mack in 2007. And again, very similar findings to what we saw from the hematology group at Dana-Farber. It's an interesting dynamic because it's fascinating that the healthcare provider is not necessarily directly addressing the patient in these interactions, but is addressing a caregiver, a very important caregiver that we also call the parent. And in multivariate analysis, what Mack and colleagues found was that it was, again, the genuineness of the interaction, even when extremely poor prognostic information was being conveyed, that allowed hope to prevail. Next slide. In addition, we think the dilemma can be resolved with an emphasis on life goals. In most of the models that the majority, I would say, of people that are on this call grew up in, we were taught to pursue therapeutic goals. Many of us might have been taught that it was almost meddlesome to consider life goals for patients. And yet now, I think we are reconsidering this. I think we bless the curiosity that clinicians have and the interest they take in the lives of patients. Next slide. And for this reason, exactly these conditions for hope to thrive, as defined by Snyder and as described by Dave tonight, the goals, the pathways of agency, are probably the things that we can do to help patients define a goal that is meaningful and attainable in their lives. Next slide. So as we move forward, we would like to be able to pursue several concepts in the research agenda that we're outlining. We're interested in mechanism, the psychosocial mechanisms along the lines of what Dr. Feldman was articulating earlier, and also neurobiologic mechanisms. On the next slide, you'll see a sagittal section of a brain to remind us that there are several candidates for involvement in the central circuitry of the hope pathway in the brain. And on the next slide, I've highlighted that the lead candidate is the hippocampus. Along with another NCTN cooperative group, specifically energy oncology, on the next slide, I show you that there is a trial that we are running right now for patients with small cell lung cancer. And in that context, patients who achieve a complete response still have as a standard of care whole brain irradiation prophylactically. And here we are asking the question in a randomization of whole brain irradiation with or without hippocampal avoidance. We do hopefulness testing before and after the radiation. And if at 6 months, we find less of a decrement in hopefulness among those who had the hippocampus protected, that would be a very interesting signal that may in fact implicate the hippocampus in the hope pathway. Next slide. We're also interested in a variety of interventions. We think that the extent of the research we can do is very broad. We think there are a lot of endpoints that we can look at, including, as Dave mentioned before, survival, including things like adherence. Dr. Hirschman has, of course, looked at that extensively, and we think hope enhancement might have an impact on that and on quality of life. And here in a summary table from our Lancet Oncology article, I'm showing you the half a dozen or so experiences in the published literature that look at various hope interventions. And in the very final column, you see that consistently hopefulness increases. But on the next slide, and this is my last slide, before I turn it back to Dave, you'll notice there's one caveat, and that is the caveat of time. Busy clinicians don't necessarily have 8 weeks, 7 weeks, oodles and boodles of precious time, maybe our most precious commodity, to invest in this. And what Dave's going to tell us about right now is a wonderful, brief intervention that can convey the essence of hopefulness as we know it.
Okay, next slide, please. So as Dr. Korn was talking about, indeed, the problem with some existing hope interventions, and there aren't a lot of them, it's a burgeoning area are that they require anywhere from about 5 to about 20 sessions. And that's a big ask for busy clinicians and also for patients that have a lot, of course, going on in their lives. And so about 10 years ago, myself and my colleague Diane Dreer sought to take some of those interventions and really compress them into a single 90-minute to 2-hour session. And you see that this is published, and this article is titled, "Can Hope Be Changed in 90 Minutes?" And I'll give you a preview of the answer. The answer is yes. And now this intervention has been used all over the world, certainly all over the country, but it's been primarily used, actually, interestingly, among college students in campus counseling centers, because you may know that there is an upsurge in depression, anxiety, stress, and hopelessness among college students. And so that's the primary population that this has been used with. However, we're now expanding this, or I should say have expanded it, into the cancer space. Next slide, please. So you see here a hot off the press, I believe that it was just published this month in JCO Oncology Practice, article by our very own Ben Korn and company that looks at the application of this single session workshop in a population of patients, a small population of patients, but a meaningful one with metastatic breast cancer, and found quite positive results. And click next, please. And we have now made an effort the last year to really claw our way into the 21st century and bring these interventions into cyberspace, into the virtual environment, because of course, the issue is that all of these past interventions have been in-person interventions, but now we're existing very much in a new world. Now, you may know that we were slated about a year ago at the last SWOG group meeting to actually implement these workshops with you all. With healthcare providers that are members of SWOG. But of course, that was canceled because the meeting was brought online. And so we've spent the last year really redeveloping this intervention into a virtual environment. You can see me on the left. You can see Ben in the upper right corner, looking very small but happy on the right. We've now piloted this intervention with groups of people around the world, including in London, in Israel, and in parts of the United States. Click next. And as part of this intervention, we have also developed an app. So this is an app that is called Hoptimize. If that's not a cute name, I don't know what is. And it's been developed in collaboration with Dr. Korn and his wife Devora and their nonprofit organization called Life's Door. And you can see that it is complete with very pretty graphics and cute cartoons, but I guarantee you it is a very serious app. And that can potentially make a real difference in people's lives that we use as part of this online intervention. Next, please. And this is really where you come in, and we hope that all of you will be willing to collaborate, to participate. So I didn't know this until recently, but did you know that May is Hope's Month? And it really coincides with our debuting of these workshops in SWOG. So we would like to invite all of you, or many of you, to participate in these workshops as participants. And there are 3 reasons why we want to do this with providers. The first one is I know of no better way than how to teach techniques for increasing hope than by modeling them and having you experience them in your own lives. In addition to that, as we talked about, we've done research showing that hope is related to provider well-being and lower burnout. And so we're going to be taking a look at that. And lastly, we really want to examine the feasibility of these workshops, and get feedback from you all, both in terms of the feasibility in your own lives as providers, but also how well you think it applies to the patients and perhaps the families that you serve. And so we have 3 of these hope intervention workshops, May 12th, May 19th, and May 26th. And many of you will be receiving in the next 2, maybe to 3 days, invitations in your email inbox. Now, these workshops are 2 hours each, and they're limited to 12 participants. So if you do get an invitation and you want to participate, click the link right away and register. We'll also have wait lists, but we really want to try to involve as many of you as we can. And also, I just want to extend an invitation that if you're interested in any of the other agenda initiatives or research projects that we're doing related to hope, we really think, as I started off by saying, that this is an under-researched but very important topic, and we want to invite you to become involved in any way that is meaningful to you. And now I'll hand it back over to Dr. Korn to bring us to the end of the presentation.
So on the last slide, if you will, an image that you've seen twice before in this presentation, I'm going to tell you a 50-second anecdote, and then thank the host for inviting us to speak with you today. As you heard, this piece was in Lancet Oncology. It was supposed to be published in August of 2020, and then I got an email from the editor-in-chief of the journal asking me if it would be okay to defer publication by 1 month. Why, I asked, and he explained that the September issue was, as Dave mentioned before, the 20th anniversary issue, and they were commissioning an artist to create cover art in which they wanted to embed this notion of hopefulness, and thereby to wink at the readership that as important as everything that's been published in there in the last 20 years is, that hope research must be part of the next 20 years of oncologic research. And I think SWOG is the vanguard of this. We're all positioned to do great things. And I hope you'll come on board and join us.
Very good, thank you. A remarkable talk, and I think it's an indicator of things to come. Dr. Bakaitis will introduce our next presentation as we move from our plenary sessions to developing concepts. So Marie, let me turn it over to you to switch to developing concepts in our committee.
Sure. So we would love to have our first developing concept presented by Dr. Chung and Sun, and this is S2016.
Great, thank you so much. So yeah, I mean, this has been, you know, a track in terms of going through the process of submitting for the grant, but I just want to give everyone an update and speak on behalf of Virginia Sun, who is my co-chair. She will chime in as needed. But this is S2016, which is a randomized phase 3 trial of a primary palliative care intervention to improve quality of life in metastatic pancreatic cancer. Next slide, please. So just to review the background, as we all know, pancreatic cancer is a very challenging disease. Patients, unfortunately, most of them will end up passing away of their disease. And there's a lot of symptoms that are involved with pancreatic cancer that really affects patients' quality of life as well as the family caregiver. Palliative care really represents an important aspect in the care of pancreatic cancer patients with aggressive symptom management and attention to quality of life, which are just critical. We all know that palliative care is the gold standard for all patients with pancreatic cancer as well as other cancers, but unfortunately there is a significant shortage of palliative care specialists, and unfortunately we don't have enough to meet current or future demands. So we really need to look at scalable approaches to meet this growing demand. So in this particular project, we're actually evaluating a comprehensive patient assessment, which can be administered centrally by advanced practice nurse, which will help to really identify needs early and help guide interventions. Next slide, please. So the objective of the study is really to evaluate patient-reported quality of life at 3 months. What we're looking for is that by doing an early intervention, that will have an improvement in the quality of life. We're also looking at secondary objectives, evaluating patient symptoms, patient distress, family caregiver distress, caregiver burden, as well as family caregiver quality of life. We really also want to look at ASCO quality metrics because I think that, you know, healthcare in the last weeks of life do take up a significant amount of resources. So we want to be able to see if an early intervention for pancreatic cancer patients will impact that. And of course, you know, based upon all the wonderful work that Dr. Bakaitis has done, as well as Temel and many others, we do know that early intervention does have an impact. We will be looking at the geriatric assessment tool in this population. We've renamed it as a comprehensive participant assessment tool because the great work that Dr. Arthur Haria did really kind of laid the groundwork for looking at functional age rather than actual chronological age, because what she was able to show was that patients that are older but with much better physical fitness, they can actually tolerate chemotherapy just as well as younger people. And I think this also goes the other way around too, because there are patients that are younger, like in the 40s and 50s, that may have a you know, functional age of a 70 or 80-year-old. So this can really significantly impact a patient's tolerance on 2 therapies due to increased toxicity. So we are going to be looking at a participant assessment tool within this project. We will be looking at hospital admission rates because we're hopeful that this will have an impact in terms of decreasing hospital admission rates, and also we'll be looking at overall survival as well as a secondary endpoint. Next slide, please. So these are the eligibility criteria. Patients need to be diagnosed, of course, with metastatic pancreatic cancer, and they should be enrolled within 8 weeks of the initial diagnosis of pancreatic cancer. We're looking at ECOG performance status 0 to 2, and currently our questionnaires are currently in English. Age greater than 18 years of age and willingness to complete the questionnaires. Now, for the family caregiver eligibility, this would be defined as a family member or friend identified by the participant and defined as a person who knows the patient well and is involved in patient's care. However, if the participant does not have a family caregiver identified, they will not be excluded from the study. Next slide. So this is the study schema. So again, patients that are initially diagnosed within 8 weeks of their diagnosis, they will complete a baseline survey. They'll then be randomized to either the intervention arm, which is 12 sessions over 3 months, which are 6 for the patients and 6 for caregivers. And this will be performed by an advanced practice nurse that will be utilizing an intervention resource manual. As far as palliative care consultations, if the institution does incorporate palliative care physicians, they can go ahead and involve their palliative care team. That's part of their standard of care. And that goes for the intervention arm as well as the tension control arm. In the tension control arm, the patients will be, again, having telephone sessions, but they will be just going over the NCI Coping with Advanced Cancers booklet, and they'll be just following traditional standard of care. We'll be evaluating them at 3-month follow-up as well as 6-month follow-up. Next slide, please. So this slide just really illustrates the sessions. So we have 6 sessions for both the patient as well as the family caregiver. And I just want to kind of highlight what will be covered with each of these sessions by the advanced practice nurse. In session 1, for example, we'll be really focusing in on physical well-being. So for the participant, we'll be focusing in on pain, which is a common symptom for pancreatic cancer patients, neuropathy, constipation, fatigue, lack of appetite and weight loss, nausea, vomiting, lack of sleep. So really, symptoms that can have quite a impact on their quality of life. As far as family caregivers, caring for the participants' physical needs as well as pain, fatigue, sleep problems, and self-care. For session 2, we'll be focusing on emotional well-being, session 3, social well-being, and session 4, spiritual well-being. Sessions 5 and section 6 will be going back and re-emphasizing items that need to be covered in more detail from the previous 4 sessions. Next slide, please. So we're all looking for everyone's participation, hopefully when we get funded. So basically what we're looking for is 170 evaluable patients. And this is what's needed to detect an 8-point difference in the FACT cap between the arms at 3 months. And what we're anticipating is that this will take about 4 years to complete. So we did submit the NIH R1 grant last year, back in June. It was reviewed and scored at the 13th percentile. So we're really close to, getting funded. We resubmitted actually March the 5th, 2021. So you can see with COVID-19, I lost a complete year. But we're going to be hopefully hearing back sometime this fall regarding the R1 grant. So crossing our fingers that we're hopefully going to get funded and we'll be able to get this project up and running. So thank you for your time. I'd like to thank everyone for their participation, and I'd be happy to take any questions.
Great. We'll have to defer the questions to the chat for right now,
Right.
so that we try to get back on time. Dr. Krauss.
Yeah, I appreciate it. Dr. Yara Solomon is going to be giving a presentation now. We have a lot of interest in medical aid in dying and trying to look at it further. Be a very novel study. And so, Yara, are you there?
I'm here. Can you hear me?
Sure.
Hi.
Let's speak up a little bit.
Okay, is this better?
Yes.
All right. All right. Hello, everyone. So I will give you an update on our pilot study, which is a limited institution phase 2 study to estimate the prevalence of depression in participants making their first oral request for medical aid in dying. Next, please. So at this point, medical aid in dying, or in some states also known as Death with Dignity Act, is legal in 11 United States venues. All of these laws require patients who are requesting medical aid in dying to have decisional capacity, but there are no formal definitions of decisional capacity that are implemented in MAID. In a small study, the incidence of true depression in MAID patients has been estimated at about 25%, but there isn't enough literature on the subject, and that number has not been really verified. Proactive screening for depression has been inconsistent across centers that participate in medical aid in dying, and we really don't know the impact of identifying and treating clinically significant depression in patients who are requesting medical aid in dying. Next, please. In one of the studies, over 50% of psychiatrists felt that depression may actually render patients to lack capacity to consent to medical aid in dying. From other studies in end of life, we know that treatment of depression reduces the desire to die. Physicians who are involved in MAID may require their patients to undergo a psychiatric evaluation for competence or decisional capacity, but they very rarely refer these patients for mental health evaluation. And from another point of view, some publications have suggested that MAID rules may actually not adequately protect patients who have mental illness. Next, please. So the primary objective of our study is to estimate the prevalence of clinically significant depression as defined by PHQ-9 score equal or higher than 10 among participants at end of life making their first oral request for medical aid in dying. Our secondary objectives include evaluation of feasibility of enrolling participants seeking MAID to a clinical trial, describing participants' willingness to complete the PHQ-9 questionnaire, ascertain rates of antidepressant use at the time of registration in participants seeking MAID, estimate acceptance of psychiatric referral for participants with clinically significant depression, and also to estimate the proportion of participants with and without clinically significant depression who actually proceed to use medical aid in dying. Next, please. The eligible participants will be patients at select cancer centers who are making their first oral request for medical aid in dying as documented by their evaluating clinician. They otherwise must be fully eligible for MAID as also determined by the evaluating physician. Their second oral request for MAID has not been made yet. They may be on an antidepressant, but they should have no history of prior suicide attempts. They need to be able to read and speak English or Spanish, and they have to be 18 or older. Next, please. This is a study schema describing the process of selecting the participants who need to meet the criteria for MAID eligibility and make their first oral request, but the second oral request has not been made yet.
If they do consent to participate in the study, they will be offered PHQ-9 questionnaire that they may refuse, but for those who accept, they will then be assessed based on the score. If they score at a moderate to severe depression score, meaning at or 10, at or higher than 10, they will be offered a referral to a psychiatrist. And then we'll follow those patients as well as the patients who scored at a lower number for the study outcomes. Next, please. As far as the depression screening and treatment in this particular patient population, the patient health questionnaire, or the PHQ-9, is a self-administered depression screening instrument which scores each of the 9 DSM-5 criteria for major depression as 0, meaning that the symptom is not present at all, or 3, that the symptom is present nearly every day. It has been validated and reliable as a measure of depression severity, including in patients with medical illness and cancer. As I mentioned earlier, patients who would score 10 or higher would be referred for further assessment and treatment by a psychiatrist, and the treatment may include medication, such as an antidepressant and or a stimulant, and in addition to that, or brief psychotherapy intervention. Next, please. Our goal is to accrue 120 patients, which should allow us to estimate the true depression rate. We hope to accrue approximately 7 patients a month in about a year and a half to complete the accrual. And the study is currently undergoing, it's been submitted for DCP review. And I believe that's my last slide.
So, Dr. Salmon, thank you very much. And we appreciate the talk. There's one question from the chat. You described the feasibility goal, but the question is, what is the hypothesis of the MAID study?
The hypothesis of the MAID study, well, we are hoping to find out what might be the true depression rate or the prevalence of depression in patients who are requesting medical aid in dying.
Well, thank you very much, and we look forward to further updates. We are a little bit behind schedule, but I believe we'll be able to make it up just fine. The next update was scheduled to be Dr. Subbiah talking about her communications intervention for providers. I think Dr. Subbiah is tied up, and I don't believe she's on, and I will speak for her briefly to say that she has a HOPE-funded study that will be an intervention to teach providers to improve their communication skills, and we hope to actually measure providers' confidence in communication before and after this intervention. So more information to follow for that. And we're ready to go on to active study updates. And if we can ask Dr. Sun to give us an update on SWOG 1820, we've been quite impressed. And this is the slide to start her comments. So please, Virginia, go ahead.
Thank you. It's good to see everyone. I will be giving an update on SWOG S1820, which is a preliminary efficacy randomized trial of what we fondly call the Altering Intake Managing Symptoms Intervention for Bowel Dysfunction and Rectal Cancer Survivors, so AIMS-RC. I want to acknowledge the really many years of support by the Hope Foundation for Cancer Research on this line of work. This concept started as a young investigator training course project where I attended and developed the concept initially, followed by seed funds to provide some small feasibility data for this intervention, to the clinical trial support funds that we are receiving from the foundation right now, as well as funding support from the R21. So thank you very much for all the support over the years. Next slide. And of course, I definitely want to acknowledge our team, my co-chairs, Dr. Cindy Thompson, Dr. Tracy Crane, and Dr. Krauss. Dr. Krauss, thank you so much for really bringing me into SWOG and helping put this concept through and supporting this study. And also Dr. Catherine Guthrie and Catherine Arnold and all of our biostatistical and data operations team members up in Seattle. And thank you so much for everything that you do for this project. Our protocol development coordination team in San Antonio. Thank you, Christy. Thank you, Gretchen. Our nurse coordinator, Christa Braun, who plays a very important role. She is really giving us the NCORP community site in sort of insight in terms of how we can run this trial successfully. Our patient advocates, Lee Jones and Florence Cretilla, and our GI committee champions, Dr. Mazen Alkas-Fools, Dr. Stacy Cohen, and finally, all the study coordinators, coaches at the University of Arizona and at City of Hope. This team meets on a weekly basis to make this trial run and be successful. So thank you all for your support. Next slide. So this is the study schema. I'm sure many of you have seen this a couple of times, even this week already. So I will go through this quickly. So in the gray box, we are focusing on rectal cancer survivors. Our target sample size is 94, 47 per arm. We are enrolling a post-treatment population between 6 to 24 months post-treatment completion. We are including ostomy or anastomosis participants. For those with an anastomosis, we will be screening them for a low anterior resection syndrome or LARS score of 21 to 42, which translates to minor or major bowel symptoms. We are focusing on English-speaking population for this trial in adults 18 years and older. We do have a after baseline surveys, a run-in period, again, just an opportunity for the participants to be able to understand some of the tools that we are expecting them to use while they're on this trial. So it lasts about 14 to 21 days. And our definition for completion of run-in is very broad, such that the majority of our participants are able to complete run-in and be randomized to one of two arms. The intervention arm, or the AIMS RC arm, is really a 10 telephone coaching call over 4 months. The sessions are about 20 to 40 minutes. We focus on goal setting, identifying and overcoming challenges. We coach participants to use the food and symptom diary to help them personalize diet modifications, and also for us to understand tolerance and preference in terms of food intake. We also apply motivational interviewing and problem solving theory to our coaching process. They will receive a resource manual and receive personalized text email messages support between the 10 calls that are really tailored to their needs. The control arm is an attention control design where we had identified 10 healthy living education topics, and these will also be delivered by telephone calls over a 4-month period. And they will also receive a resource manual. The text and email messages here are automated standard messaging based on the 10 topic that we have chosen. The intervention is all centrally administered by telephone by trained health coaches at the University of Arizona. We complete 2 additional follow-ups at week 18 and week 26, primarily with patient-reported outcomes. Our primary outcome is bowel function, is measured by the Memorial Sloan Kettering Cancer Center Bowel Function Index. And we have several secondary outcomes, including quality of life. We will look at the LARS score, several constructs related to the framework that we are using, such as self-efficacy, motivation, affect. We will be able to look at diet quality through the 24-hour dietary recalls, and also still be assessing feasibility, adherence, and acceptability. Next slide. And so I wanted to share a little bit of our strategies that we've used in terms of site and study team engagement. And many of these strategies have been borrowed from other successful trials that have been previously ongoing or completed, and also with the support of our recruitment and retention committee. So as I previously mentioned, the primary research team, the core research team, the protocol team meets every Wednesday. and our call lasts about 30 minutes or so, just as an update on accrual and also a way for us to discuss any particular challenges that we've heard from the sites and address them. And when a revision is needed, this is where we talk about what to do as well. We do have mandatory site training to be able to activate this trial. And these are recorded webinars to make it easier and more flexible for site coordinators and site PIs. We do have a monthly site coordinator call every third Thursday of the month, which for me, as a study chair, is where I really can be able to hear sort of some of the suggestions and feedback from the sites. And we have regularly had 28 to 30 participants every month since we started the coordinator calls. We also create a study protocol cards. As you can see, there's a picture here of the front and back. It's a pocket-sized protocol card that's laminated that has some key eligibility criteria information, the study design, that the site team can pass out to clinicians and site investigators to put in their pocket and be able to access information on the study and eligibility really quickly. I personally try to do monthly engagement with the site PIs investigators where I know them, have a communication with them and try to really actively reach out and see if I can help. And we can help with any, if they have any concerns or questions. And we also sent out a monthly accrual graph with which I will be showing in the final slide, which is the next one. And also this protocol does allow non-physician investigators to enroll. So APPs who are registered non-physician and non-investigators within SWOG can enroll and serve as site PI if needed on the trial. So this is the accrual graph. Many of you may see it every month, pretty much on the first or second day of the month. This graph is sent out as an update to all site investigators and site coordinators to give an update. This is our April 1st update. So we've been activated since December 9th, 2019, and I'm happy to share that we're about 53% accrued, 49 randomized. I think this number may have gone up already since I last updated this slide. So we are very grateful to all the support from the sites and the accrual. Thank you, Dr. O'Rourke, for your support of the trial and at your site as well. And we also have a publication that is just recently accepted. It's a protocol paper just describing our design in the Contemporary Clinical Trials Communications Journal. And this is my contact information if you have any questions. Thank you again for the time.
Well, Virginia, thank you. And I want to brag about my Prisma Health Cancer Institute. We are among the leaders. And I just can't read the print on the others, so forgive me for failing to give credit to the other 3 sites that have accrued 5 patients, but it's a good study and a patient-friendly study, and the world of rectal cancer is evolving rapidly, and these kind of symptom control-oriented patient experience things are critically important. So we are still going to finish on time, and I'd like to go to the next slide. And this is new business. And Dr. Dyson, I'll ask you to come to the microphone if you're available, just for a brief discussion of a new concept that's in the thinking stage, I guess.
Well, Don, if you want to introduce Dana, maybe Don would. I know Don's on. I don't know if he's on the speaker list.
Hi there.
If you're here, maybe introduce yourself.
But then I'll just Dana. So Dana Geyer is a colleague of Don's. She's a palliative care physician, and we're starting to work through a concept of intimacy for patients with advanced cancer. So Dana, do you want to?
Yes, absolutely. Thank you for having me. I'm Dana Geyer. I'm one of the palliative care doctors at Rhode Island Hospital and the Lifespan Cancer Institute. And Don and I have been thinking about, with Robert, looking at the sexuality and intimacy in patients with cancer who are receiving palliative care. And what we've been wondering is, do issues of sexual health interest palliative care cancer patients? What are the sexual health issues that interest these patients? And then do clinicians talk to palliative care patients about their sexual health? And so We did a little literature. There's very little in PubMed about sexuality and palliative care. There are no prospective interventions. There are really fewer than 20 articles that specifically address the sexual health needs and interests of palliative care cancer patients who have a limited life expectancy. And those articles are primarily narrative or case-based. So even though the literature is sparse, there are some important points that palliative care cancer patients report a change of meaning and sexual expression regarding their sexuality and sexual health. That skills training and increased availability of patient information, skills training of healthcare providers, and standard integration of psychosexual support does improve sexual health for patients. That healthcare providers have an important role to speak openly about these issues with their patients, and that further training of healthcare providers would be very valuable. Anecdotally, the majority of patients consider sexuality and sexual health discussions very important. So what we're proposing is a patient survey via REDCap that would target patients with advanced solid tumor malignancies who are established with a palliative care provider for at least 8 weeks at the SWOG sites. And it would be an open survey that runs over 12 months with a qualitative design. Our hypothesis is that patients with cancer and a limited life expectancy who are receiving palliative care are interested in topics related to sexual health, including intimacy, sexual identity, sexual functioning, and sensuality. Our objectives would be to conduct an assessment around sexual health interests and needs for oncology patients receiving palliative care, with secondary objectives to determine areas of interest within the domains of sexual health, which are intimacy, sexuality, sensuality, arousal, body image, sexual satisfaction, and desire. And really to determine the priority level that patients assign to sexual health issues. We're also looking to determine opportunities for further engagement in research surrounding sexual health and palliative care patients. So it would be a one-time survey using REDCap with self-reported demographic data. And the survey will use some targeted and specific questions from NCCN and the PROMISE database, as well as the PAIR study that will look at intimacy, desires, and will expand based on patient answers. Some of the questions that we're thinking about, just do you have any concerns regarding your sexual function or sex life? Do you feel distant from your partner? Are you satisfied with your sex life? Is sexual expression a part of your relationship, and so on. We think this project has a lot of value, and that despite a lack of literature, anecdotally, patients and their partners express a true interest in sexual health, even in the very final months of their life. And this survey project would establish a baseline knowledge about what matters to patients with cancer and a limited life expectancy receiving palliative care, and would help us set the stage for further research to improve communication regarding sexual health for these patients, and also provide rationale for future sexual health interventions for palliative care oncology patients. So that's what I wanted to say. I'm happy to send out the slides. They didn't make it into the slide deck, but I can send them out to be seen if that's helpful.
Thank you. If you'll send them in, we'll distribute them, and more to come on this, and feel free to email the co-chairs or Dr. Krauss or Dana to discuss further. We're close to wrapping up. I want to mention just two things briefly. I'm getting feedback. It's something, well, we'll have to live with it. We're going to be sending out a request for concepts for the Palliative Care Committee. The Palliative Care Committee has an interest in developing advanced care planning process, efficacy, and effectiveness concepts. And we're also interested in patient, family, and caregiver communication, as well as in specialty and primary palliative care. So you'll be seeing by email and in different media sources through SWOG a request for concepts. We don't have funding for it, but if you'll forward the concepts, we'll help develop them and get funding. And finally, we've been working closely with the Palliative Care Research Consortium, and we had intended for Dr. Bakaitis to give us an update on that working relationship. We've run out of time, but you're encouraged to join us in our monthly calls, and we get an update from the PCRC, and that's turning out to be a useful interaction. I'd like to thank all of you.
I'll put something in our minutes, Dr. O'Rourke.
Okay, so I'd like to thank you all for participating, and I will sign off for myself and give Marie and Robert a chance to say goodbye as well.
I'll just thank everybody for participating. It's hopefully next time we'll be in, seeing each other, or at least a lot of us will be seeing each other in person, but it's not the easiest, but I think that things are moving along as a committee, and we're really proud of everybody's what they're doing, and look forward to continue updates. We encourage everyone to come to our monthly meetings. We really appreciate the involvement. Marie, anything you want to add?
Nope, ditto. Thanks.
Right. Thanks a lot. Take care, everybody.
Okay.
Very